Spinoli. Today I will discuss diabetes mellitus type 2. The topics I will cover include the prevalence and diagnostic criteria of the disease, pathophysiology of diabetes mellitus type 2, and how this disease can be discussed in an understandable way with your patient, signs and symptoms of diabetes mellitus type 2, as well as disease management, which includes lifestyle modification and medical management, as well as chronic complications. In diabetes mellitus type 2, your body has trouble moving glucose from your blood into your cells for storage, which depletes your cells' glucose storage. With glucose being stored for energy, a depleted glucose reserve causes cells to starve for energy. A diagnosis of diabetes mellitus type 2 is defined as an A1C at 6.5% or higher, a fasting blood sugar of 126 milligrams per deciliter or above, or a glucose tolerance test result of 200 milligrams per deciliter or higher 2 hours after an oral glucose tolerance test. Global diagnoses have increased. The global estimate is 415 million individuals with a diagnosis of diabetes mellitus, increased from 30 million cases in 1985, with the prevalence of type 2 diabetes mellitus rising much more rapidly than seen in the global diagnosis of type 1 diabetes mellitus. Pathophysiology. The pathophysiology of diabetes mellitus type 2 can be seen as broken down into 3 categories: beta cell dysfunction, insulin resistance, and hepatic gluconeogenesis. Pancreatic beta cells release insulin in response to high blood glucose concentrations. In type 2 diabetes mellitus, insulin secretion is reduced. This limits the body's capacity to maintain blood glucose levels and ultimately leads to an inability to maintain glucose homeostasis. Insulin resistance occurs when prolonged plasma glucose contributes to a decrease in skeletal and liver cells' sensitivity to insulin, which acts like a key and opens the pathway for glucose to be stored in these skeletal cells and liver cells as energy storage. Hepatic gluconeogenesis increases plasma glucose. The gluconeogenic pathway from alanine to glucose is more active in insulin deficiency, and ALTs may contribute to increased gluconeogenesis in type 2 diabetes mellitus. In fact, insulin resistance acts as a positive feedback mechanism with pancreatic beta cell dysfunction, because the insulin-resistant organs require a greater release of insulin by the pancreatic beta cells, but the pancreatic beta cells cannot keep up, so the dysfunction is heightened with the insulin-resistant organs requiring higher levels of insulin release. How to discuss this with your patient. This disruption in the balancing of glucose levels occurs from an inability to produce enough insulin and from the body's reaction to the insulin that is released. Insulin helps open the door in cells found in the liver and skeletal muscle that store glucose for energy. Initially, the body is producing large amounts of insulin in response to elevated blood sugar levels. This increase in insulin causes a desensitization in the body. From increased exposure to the insulin, the body becomes less sensitive when it is released. This can be compared to a person that wears glasses. At first, it is obvious that the glasses are on their face all day, but after the body is exposed to the sensation of the glasses being on their face over an extended period of time, they forget they're there. This is similar to insulin resistance and the key difference between type 2 diabetes mellitus and type 1 diabetes mellitus. Insulin resistance is the greatest contributor to elevated blood glucose levels seen in type 2 diabetes mellitus. However, it has been found that the body's insulin producing cells will ultimately have trouble compensating for the amount of insulin that the resistant organs need to recognize insulin and use it to initiate the transportation of glucose into their storage cells in the liver and skeletal muscle. Diabetes mellitus type 2 has both acute complications as well as chronic complications. Signs and symptoms of the acute complications of diabetes mellitus type 2 include extreme thirst seen in hyperglycemia, as well as frequent urination, tiredness, fatigue, nausea, and dizziness. Signs and symptoms for hypoglycemia include racing pulse, cold sweats, pale face, headache, increased hunger, shivering, weakness, feeling restless or anxious, difficulty concentrating, confusion, and in severe hypoglycemia, coma and death. Hyperosmolar hyperglycemic non-ketotic syndrome. In hyperosmolar hyperglycemic non-ketotic syndrome, blood sugar levels rise and your body tries to rid itself of excess sugar by passing it through the urine. Initially, you experience polyuria, which is increased frequency of urination. Eventually, you may not have to go to the bathroom as often and the urine becomes dark. Without increased hydration, severe dehydration can occur and potentially lead to seizures, coma, or even death. You may be very thirsty, but even if you're not thirsty, it is very important to consume a lot of liquids to prevent dehydration. Some warning signs include blood sugar levels over 600 milligrams per deciliter, a dry mouth, extreme thirst, warm, dry skin without sweat, a high fever, sleepiness or confusion, loss of vision, hallucinations, and weakness on one side of the body. Management of type 2 diabetes mellitus. Management for type 2 diabetes mellitus can include a number of things. Self-management is required in order to achieve effective management of type 2 diabetes mellitus. This includes self-monitoring of blood glucose, nutrition therapy, regular exercise, individualized drug therapy, oral glucose lowering agents, and the prevention of acute and chronic complications, including hypo and hyperglycemia. In type 2 diabetes mellitus, weight reduction is a key element in improving glucose tolerance. Diet and exercise can prevent or delay onset and reduce its complications. Overall, the goal of management is glycemic control. With type 2 diabetes mellitus, the first intervention would be lifestyle changes. Lifestyle changes include diet, exercise, and weight reduction. If a person's hemoglobin A1C is 7.5% or higher, monotherapy with metformin and a reevaluation in 3 months is appropriate. Metformin is the gold standard preferred treatment for type 2 diabetes mellitus and is the only approved treatment for pregnant women and children. If the target A1C of 7.5% or less is not met, another agent should be added, so the patient would receive metformin and another oral medication. These first-line medications include glucagon-like peptide 1 receptor agonists, dipeptidyl peptidase 4 inhibitors, alpha glucosidase inhibitors, meglitinides, sodium glucose inhibitors, sulfonylureas, and TZDs or glitazones. If an A1C of 9.0% or greater is found after dual therapy is initiated, a third agent can be added. A third oral agent can be added to achieve optimal blood glucose levels, and insulin therapy should be considered. Intermediate or basal insulin added at bedtime can be a very effective way to achieve optimal blood glucose levels. Blood glucose monitoring. Managing blood glucose levels is the key to reducing chronic complications and to reducing day-to-day symptoms. Self-monitored blood glucose logs are essential when monitoring therapeutic response to medication. Chronic complications include microvascular and macrovascular changes, as well as complications from neuropathy. These are some of the greatest contributors to the morbidity and mortality rates among diabetics. Some microvascular complications include nephropathy, neuropathy, and retinopathy. Macrovascular complications include coronary artery disease, cardiovascular disease, and peripheral vascular disease. Diabetic foot ulcers, infections, and skeletal fractures are some additional complications that contribute to the morbidity and mortality rates among diabetics. Patient education is key when treating and managing type 2 diabetes mellitus. A lot of the management occurs in the household with glucose monitoring and compliance with medication, as well as with diet and exercise. It's important that we keep our patients educated and give them resources outside, such as the American Diabetes Association websites and information gathered by the CDC. Thank you for listening to my presentation. I hope you learned something.